Perfect. All right. Well, good morning, everyone, and welcome to another installation of NB Heart Center CV Weekly Rounds. This week, we have Dr. Stephen Robinson from the Division of Infectious Diseases. Steve's originally from Sussex and did his internal medicine here in St. John, but went out to Calgary and did his ID there and has been back on staff for, I would say, is it about 3 years now? 4?
It's almost 5.
5? What
It'll
happened
be
there?
5 in August.
Okay,
Yeah.
there you go. Time flies clearly, and he's been obviously a great addition to the program, and him and his colleagues have done a lot really to look at the IV drug user population, and especially as it relates to endocarditis. This is an area that is close to our hearts in the cardiac surgery / cardiology world, and as we're learning, especially in this particular population, there's so much more to infective endocarditis than just the management of the infection. And Steve and Duncan have a really kind of a nice sort of approach to these patients, which looks at, the control of their infectious disease, but also their, the overall harm reduction. So I thought this would be a great opportunity for us to discuss this particular issue, and especially timely given some of the recent cases that we've had on our service that have posed some, challenges both clinically and socially and ethically. So Steve, I'll pass it over to you. Thank you so much.
All right, thanks, Ansar. And it's an honor to be asked to speak at this weekly round. Sorry, I call it the CV surgery rounds. It seems like it's much more than that, and I recognize that. So I'm certainly honored to be here, and this is certainly something that's kind of near and dear to my heart, and happy to have the opportunity. So quickly, 20 minutes is a short amount of time for a pretty big subject, so I'm going to try to hit the high points here. The game plan is pretty simple. First of all, we'll establish, is injection drug use associated endocarditis a problem? Now, anecdotally, I think we can all say we're seeing more of it, and we'll look at some of the data that kind of bolsters that anecdotal thought. And then we'll go into the harm reduction approach. So what can we do beyond treating the infection? Because I think we're all pretty good at treating the infection and doing the medical side of things, but there's a lot more to it, as Ansar said. So we'll start off with some epidemiology. Are we seeing more is the big question. And I would say absolutely, especially in the last year or two, it certainly feels like it. And we'll start with some American data and then work our way more locally. So this is a study out of North Carolina that looks at rates of hospitalization for infective endocarditis by drug use status. And as you can see, from 2007 up to 2017, there's a significant increase in the number of hospitalizations related to infective endocarditis among patients who inject drugs. And further to this, you can see that not only are they being admitted, but a lot more are being operated on. So there's a 13-fold increase in valve surgery among patients who inject drugs with endocarditis from 2007 to 2017. And in the end, at the end of their study, they found that it actually was associated with 42% of all of their infective endocarditis surgeries, which is a significant proportion and a heck of a lot more than they had been seeing initially. And there are other studies that show very strikingly similar numbers. There's a study from the Annals of Thoracic Surgery that showed a year-on-year increase up to the 40 to 42% range in terms of proportion of patients with injection drug use associated endocarditis of their patients that they're operating on for endocarditis. So seeing dramatic shift in the demographic and clinical profile of the patients undergoing surgery. So certainly we're seeing this all over. This is an interesting graph that's a little less specific to cardiac surgery, but I just find it fascinating in the way this study presented. This is from CMAJ in 2019. This is two plots, and the red line is the number of injection drug use associated, just number of cases of endocarditis in London, Ontario. And superimposed on that plot that is increasing over the years is the number of prescriptions of hydromorphone contin. And so this shows us two things. One, that yes, we're seeing a lot more endocarditis. Two, that it's probably related to injection drug use. And I guess it's showing us three things: that there may be a correlation between that and the prescription of hydromorphone contin. Now, the people who did the study went on to do some very interesting work proving that the certain components of the contin formulation can facilitate growth and culture of microorganisms, including HIV, Hep C, and bacteria such as Staph aureus. And among injection drug users, they'll often share the wash. So when they take the contin, they put it in a cooker, they mix it with some sterile water, or ideally sterile water, and let it dissolve. And they'll often get a number of hits out of that, and they'll often share it with other injection people who are injecting drugs. And they found that not sharing needles to be the problem, but sharing wash, particularly when that wash contains cotton beads that has the certain molecules like cellulose that can help promote the growth of these microorganisms. And they went on to show that cooking your wash can actually kill these microorganisms and statistically significantly reduce the risk of bloodborne pathogen acquisition as well as severe bacterial infections. Fascinating work out of London. I won't say too much more about it, or I could spend the whole time talking about it. But let's move locally. So this is a study that was presented at a conference by Tommy Brothers, who I believe is presented to the Atlantic cardiac surgery symposium at some point about harm reduction. They looked at local numbers here, and it's small numbers, granted, but you can also get a sense that the large blue bar, which is the St. John Regional Hospital, has seen an increase in cases over the years. Now, this is just looking at 2013 to 2017. And I got here around 2016, 2017. And certainly I feel that that number is increasing. And ideally, we would continue to look at that data to show that rise. But even locally, we have some numbers to suggest that the cases are increasing. So how bad is it? Like we're seeing more of it, and that seems to be a trend all over North America and here. And so getting a sense of, okay, we're seeing a lot more of it. How significant is this? How aggressive do we need to be about it? So when we view right-sided endocarditis, we generally think of it as a low mortality infection. So this is mortality in patients with right-sided endocarditis, generally injection drug use associated. And approximately 6% is relatively low when you look at all comers with endocarditis. Now, if we break down the right-side endocarditis further, though, large vegetation versus a smaller vegetation with a cutoff of 2 centimeters can predict a much higher mortality. So 25 to 30% mortality if the vegetation is greater than 2 centimeters, and 3 to 4% if it's less than 2 centimeters. And then, as we all know, the mortality can significantly increase if left-sided valves are involved. So aortic or mitral valve endocarditis can be much worse. So it is a disease that has the potential to have significant mortality, certainly significant morbidity. And unfortunately, 50% of patients who develop an injection drug use associated endocarditis will relapse. And we know that each subsequent episode of injection drug use associated endocarditis, or endocarditis in general, if you get it again and again, your mortality continues to increase. And this is a Kaplan-Meier curve that shows, or it's a survival curve for patients who have endocarditis once and then who have repeat endocarditis. You can see the curves diverging quite a bit there with a decreased survival in those who have repeat episodes. And the strongest independent risk factor for injection drug use for recurrence of endocarditis is ongoing injection drug use. Now, before we move on to what we do about that, let's look locally. This is back to that study that Duncan and Tommy and Steph put together a few years ago. The mortality here among the patients who inject drugs, now it was only 42 episodes, was pretty high, 31%, again, small numbers. And that seemed to be pretty split between first episode and subsequent episodes. So the 5 of the 9 who died were first episode, and 4 of the 9 who died were recurrent episodes. But the big thing to draw from here is that 2/3, so 69% of people needed to be in the ICU. I guess the other big thing is that, a lot of people did die. A lot of people end up with ongoing valve dysfunction afterwards. And people require a long course of intravenous antibiotics. So it's a high morbidity, high mortality infection, even locally. Now, if we break the numbers down a little bit further, this is a really interesting study out of the Annals of Thoracic Surgery that tried to look at outcomes after surgical intervention for endocarditis and kind of roughly when, if there's worse outcomes, when they occur. And so it's interesting, early on in the first 90 days, it seems as though people who had operation for injection drug use associated endocarditis compared to those who had operation for non-injection drug use associated endocarditis had similar outcomes, with a hazard ratio for death or reoperation in the first 90 days of 0.38 for those with injection drug use associated endocarditis, so maybe even protective. But beyond that 90 to 180 days, that risk of reoperation and death dramatically increases with a hazard ratio of 9.8 for death or reoperation. But as you get back to greater than 180 days, that hazard ratio comes back down to 1.77. So In the long run, patients with injection drug use associated endocarditis who require operation seem to do as well as patients with non-injection drug use associated endocarditis. However, there does appear to be this high risk period, at least based on this study, from day 90 to 180. Now, the study wasn't really designed to look at why, but some of the thoughts were many of these patients may have undergone rehab or detox, or undergone a detox program, and those may have ended closer to that 90-day period. And often people who undergo detox or rehab are at higher risk of overdose because their tolerance decreases, and then they have a high rate of relapse if they're not on long-term metaclosis or opioid agonist therapy. Some patients may not have just been as closely followed medically because they've made it through their intravenous antibiotics, they made it through their routine follow-up for endocarditis, so maybe they're just less engaged in the healthcare system at that point. So this appears to be a crucial time to continue engagement in our patients who do require operation. So I'll come back to that, but in the meantime, what can we do? So I think this is a population where it's very important to utilize a harm reduction approach to injection drug use associated endocarditis. And the first principle of injection or of a harm reduction, I think, is summed up best by this tweet that I've been using for about 3 years now. But basically, step one in harm reduction: don't be an asshole. So I apologize if this is put up on YouTube, which I believe it is. You can censor me if you'd like, but really, it's about compassion. It's about approaching patients and meeting them where they are, and just keeping an open mind and understand, what led them to develop this addiction and end up with this life-threatening infection. I like to frame it this way, just because this is kind of the background I like to use before I go into the specifics. So these are some big picture things, but I think as a society, we have to understand people use drugs, and that's just always going to happen, whether it's illegal or legal. People are going to use drugs, but we really have to understand that addiction is a disease. It's a chronic, remitting, relapsing disease. It is extremely, extremely recalcitrant at times, and it's not a moral failing. Many people who end up with severe opioid use disorder don't end up there because they woke up one day wanting to inject drugs. It's usually rooted in significant trauma and very, very difficult social circumstances. And as a sequelae of addiction, most specifically injection drug use, we see overdose deaths, we see bloodborne pathogen outbreaks, we see severe bacterial infections, for example, endocarditis. And there are steps along the way where we can mitigate some risk. And so we get to these points, these overdose deaths, these severe bacterial infections, because of high risk use. Overdoses often occur, less often here, but certainly, well, it still does occur here, but certainly we hear more about it out west with the poisoning of the drug supply with illicit fentanyl. And then sharing of paraphernalia is one way to certainly initiate bloodborne pathogen outbreaks. Now, sharing of paraphernalia, that's easy. We have a very evidence-based approach through needle exchange and provision of safe injection equipment, and further to that, even safe injection of clean drugs or unadulterated drugs. High risk use and poisoning of the supply, again, needle exchange, safe injection sites work for that, but the ideal approach would be to get someone on opioid agonist therapy if they're ready to engage. And this provides an opportunity for them to, remove that high risk use. If that's not an option at the time, there's definitely data to suggest that supervised injection of diacetylmorphine, which is heroin, or hydromorphone can be very effective at retaining and engaging patients and reducing risk. And then there's more and more studies looking at safe supply, which is provision of a safe amount of hydromorphone, for example, daily dispensed to patients to avoid accessing drugs in the illicit market. So these are big picture approaches. And you're probably wondering, well, I'm just really most worried about the patient who's sitting in front of me with severe endocarditis. So I think the biggest thing we can do up front is to put ourselves in our patient's shoes. I think we need to understand that a lot of patients admitted with injection drug use associated infections have a long history of chronic and recurrent trauma. They're often homeless or unstably housed or previously incarcerated. They have little to no social support, often given up on by family, friends. Many bridges have been burned at that point in their addiction. And they're admitted to a place where they often feel judged or stigmatized. The majority of healthcare contact with patients who are struggling with addiction are not necessarily positive experiences. And then to be admitted with a severe infection that's requiring significant intervention can be traumatic on its own on a background of severe trauma. often these patients are also experiencing really poorly managed pain and withdrawal, and that's not a slight at anyone. I struggle with this too. But a lot of times, at least in the early stages, there's significant pain and withdrawal that is driving a lot of the maladaptive coping mechanisms that patients are engaging in when they're in hospital. And you throw on top of that what to them is a cry for help, but to many is perceived as drug-seeking behavior. It's seen as this kind of butting of heads, or it's seen as drug-seeking behavior, and it's not often acted upon. And so if we can kind of frame our approach to these patients in a way that we know or have a sense of what they're experiencing when they're going through all of this, it really helps us understand why they're asking for what they're asking for, or maybe why their coping strategies are so different from ours, because that's what they know and that's how they've had to survive. Now we can take that perspective and really engage our patients. I think the biggest thing is just really try to keep our patients engaged, because you can't help someone recover if they're dead. If someone is not in the hospital to get the treatment they need because they've left AMA because we're unable to engage them or manage their withdrawal, they're not gonna survive, or they're not gonna do well. And the ways we do that is through using harm reduction and trauma-informed care principles. And by that I mean just recognizing and acknowledging trauma. You don't have to meet it head on or ask them specifically, like, did you have child abuse as a child? But acknowledging that they likely experienced trauma is a big step. And you take that understanding and you build trust and you create a safe space that allows them to share with you their concerns and share with you their experience. And that helps frame things so you can help start to establish goals. Is their goal to stop using? Is their goal to use less? Is their goal to use more safely? Not everybody's at the same stage of their journey, and you can really kind of help establish that early on if you've built this trusting relationship. And the big thing, even just medically speaking, just effectively managing withdrawal and pain. Now, there's always concern that giving opioids in the hospital is going to contribute to or exacerbate addiction. But really, by the time patients are in the chronic stage of their addiction, they're not really getting euphoria from their drugs. They're really trying to just maintain some level of normalcy. They're trying to avoid withdrawal. They're trying to treat pain. It's not often that they're seeking the euphoric effects of the drug at that stage. And so often up front, we have to just try and weather the storm, or really give what's necessary to engage the patient, get them through the acute phase of their medical illness. And then as the storm clears, start to engage in more long-term treatment plans. By weathering the storm, I mean managing pain and withdrawal, which does often require providing short-acting opioids and titrating to effect. Often patients up front aren't ready to start opioid agonist therapy, but the goal is to eventually transition them to it. But if they're in severe withdrawal, or if they're having severe pain, Suboxone isn't a great choice initially. We do have to help settle that down, weather that storm, and then move forward. And often while weathering the storm, patients will continue to inject. That's just the fact of life that we have to accept. And providing safe injection supplies does not encourage or condone use, because often it provides an option between reaching into the sharps container and grabbing a used syringe, or using a clean syringe that's provided from a supportive care provider. And so we do this on 4C North. We have an intravenous needle exchange policy that has been very effective at engaging our patients and reducing risks of bloodborne pathogen infections and bacterial infections. I'm sure many of you have seen the patients who come in with a single bacteria as a cause of their endocarditis, and then ultimately end up with 3, 4, 5, 6, 7 organisms in their blood. I've seen reports of up to 15 because they've continued to use in the hospital, but have not been provided the safe injection supplies, which is more than just needles. It's sterile water, it's alcohol swabs, it's cookers. There's a number of things that we can access from 4C North, but also from places like Avenue B. And eventually, as you weather the storm, the sun comes up, and you can start to move on to more long-term options for our patients, namely, from the medical standpoint, opioid agonist therapy, which is a highly effective way to manage severe opioid use disorder. And it's the pharmacologic therapy for opioid use disorder that generally includes methadone, buprenorphine, or slow-release oral morphine. Now, buprenorphine is otherwise known as Suboxone. Slow-release oral morphine is also known as Cadian. These are things you've probably seen us prescribe. What it does, it suppresses cravings and withdrawal and blocks the effects of other opioids, which can reduce high-risk behaviors. But the big thing for me that I've really come to understand lately is that it helps people engage in pro-social behaviors. because they've had to engage in pretty antisocial behaviors to access drugs when they're in the throes of addiction, whether it's prostitution, begging, stealing, borrowing, burning bridges among their family members. This removes that need or that drive to get the next fix because you've satisfied that opioid dependence with an opioid agonist treatment that is safe, daily administered, and very effective. And the data suggests or shows us is very clear that it saves lives. Methadone has been shown to reduce all-cause mortality by 69%. A lot of this is driven by overdose deaths. Same with buprenorphine, all-cause mortality reduction by up to 55%. And a Cochrane review showed that opioid agonist therapy in general statistically significantly reduces illicit opioid use, injection for endocarditis, that's extremely important, and sharing and reusing of needles, again, very important in the setting of endocarditis. Now, the goal with this is to go from this cycle of trying to just remain normal, remain out of withdrawal, remain out of pain, and get into this smooth, more long-term maintenance phase that will allow patients to re-engage and exercise safer practices. And taking this one step further, aside from just starting patients on opioid agonist therapy, addictions medicine consult service, which is certainly something seen in the States, and definitely it started in Calgary after I left, but I've heard excellent work being done in Calgary from the addiction service, can show a significant, when they're involved in cases of patients admitted with severe infections related to injection drug use, significant reduction in remission-free survival. In this study, patients were 32 times more likely to receive treatment for opioid use disorder, 6 times more likely to complete antibiotics, and 80% less likely to leave against medical advice. So this is a service that really optimizes engagement in care of their patients, and then subsequently helps to get them on opioid agonist therapy, which subsequently reduces readmission-free survival. Now, after discharge, we do know that patients can do well on opioid agonist therapy if they stay on it. Now, this study looked at patients who were started on opioid agonist therapy within 3 months of discharge from hospital, and then they broke it down further to see how they did during the month that they were on methadone, and they found that alone, just looking at people who started 3 months after discharge from hospital, the mortality was no different because a lot of people, up to 40%, stopped their methadone within a few months of being, or opioid agonist therapy within a few months of leaving hospital. Oh, sorry, I'm starting to run over. But when they broke it down further, there was a 70% reduction in mortality during the month the patients remained on opioid agonist therapy. And so if we take this data and take the data that shows this high risk period between the 90 and 180 day mark post-operatively, and we can optimize the care of our patients as an inpatient, but also as an outpatient, i.e. provide comprehensive inpatient to outpatient harm reduction management, we really may be able to impact care in these patients, even the ones that do require surgery, which is a really high risk or a high risk population for relapse or mortality. So what we're proposing here is a harm reduction service. We're in the process of submitting an application for a harm reduction service that would include a multidisciplinary team, which would have a clinical nurse specialist, a physician, a social worker, ideally a psychologist, and ideally a peer navigator to help patients from day one of admission until they're re-engaged in the community, to not allow them to slip through the cracks, to ensure they remain engaged in the community and ensure that we can overcome that high risk period of increased mortality in the post-operative period. So in summary, prevalence is increasing, high morbidity, high mortality. We need to engage our patients and treat withdrawal and pain, initiate opioid agonist therapy when able, and then connect with community resources. And that's something that I still struggle with, particularly where we're provincial or Atlantic Canadian service. That can be difficult in more remote settings, but I'm starting to build relationships in other centers, and I've been finding better ways to get people treated where they are. Just want to acknowledge Dr. Webster, Dr. Brothers, Dr. Davidson, and the Recap Clinic for amazing harm reduction work. And then sorry for going over any questions. I really apologize for being late.
That's great, Steve. Sorry to rush you. I mean, I think I just want to give some people a chance to ask the odd question, but maybe just if anybody has any questions, feel free to fire. I'm going to leave the summary slide up because I think it kind of just highlights a lot of what it is that you just said. And I think the strategy of a harm reduction team is so key. I would just say, globally speaking, one thing that, having just experienced a case, in the last week and a half where we can do the surgery piece. That's where we're trained. That's where we're, we've got that part nailed. and we can manage them clinically. But as a whole, you know, and I'm not just including physicians, I'm including the nurses, et cetera, you know, we're almost not kind of mentally hardwired to handle these types of cases. And, you know, much like when delirium rears its ugly head and we get patients, the 5 to 10% who are just totally not in their normal mindset, they have such a cognitive, you know, cognitive lapse, and you know they're hard to manage. Similarly, these people are hard to manage because we're struggling with so many other issues. So I think I think you framed it nicely, which is that, you know, we have to kind of take a step back. And to some extent, you know, much like, you know, people undergo sensitivity training and all of those types of things, I think especially cardiac, because we deal with so many of these people and an increasingly, you know, large number of these people. Um, it may be beneficial when this harm reduction team comes into play to have, you know, a kind of a weekend retreat where we sit down and we kind of go over how to deal with these people. Because as much as it's great to have a harm reduction team that you can call 24 hours a day, 7 days a week, I think as a group, we need to be better equipped to learn how to kind of deal with these people so that we're not taking the same cookie cutter approach that we have for a 65-year-old that had an AVR for aortic stenosis and applying it to the 32-year-old who's had a lifetime battle with IV drug use or injection drugs, as you said, and is now trying to undergo surgery, recover from surgery, and still be, you know, fight the demons that he's been affected by.
Yeah, well said. I agree. I think I guess the preface all this, it's certainly it's easier said than done. Like I say, a lot of these principles and a lot of this engagement in the presentation, as though it's very easy, but it's a complex process that does require a change in the way we think. You know, prescribing significant amounts of hydromorphone to someone who's actively injecting drugs, that's a bit of there's some cognitive dissonance there, and it takes a lot to overcome that. And I think, you know, approaching it in that you know, taking that step back, taking a different perspective, and understanding what the patients have been through is important. And I agree. A big part of our proposal for this harm reduction team is education, because I find on wards other than 4C North where this isn't as commonly dealt with, though CCU and 5B North are certainly getting a lot of experience over the last couple of years. There are a lot of questions. They're always very good questions. A lot of people are willing to do the right thing or interested in doing the right thing. It's just what is the right thing? How do we approach it? And I think providing longitudinal education will be a significant role of this team. But I think it would be fantastic to have some sort of retreat where we can have someone come in and speak on trauma-informed care and motivational interviewing and some of the approaches just interpersonally with these patients to help kind of people wrap their heads around a little more and engage these patients a bit more effectively. Because I get it, it's tough. It's been a journey for me to try and work with this population. And I still struggle, and I still try to learn. I still try to get better at it, but it doesn't happen overnight. That's for sure.
And, you know, I mean, we're classic for kind of operating on these people and then discharging them and kind of washing our hands of the whole situation, right? And then when we get the relapse, because I mean it does happen, and we get the, you know, with the, you know, you get the revolving door effect, it's kind of like, well, I don't know, I held up my end of the bargain. What did you do to hold up your end, right? So there's just, I think there's a mindset change that needs to occur as a whole. I think JF kind of, you know, succinctly kind of summarized that there needs to be a heart center strategy around this, and, you know, having champions, like, you know, at all levels is really key, so that, you know, we're not, you know, it's not one person fighting against the rest of his colleagues or her colleagues. It's, you know, this is a group approach. One question: how do you decide what dose of opiate to use when you're recently admitted injection drug use patient complains of severe pain?
Yeah, so that's a definitely a moving target. Often I'll talk to the patient and try to get a sense of how much they're using, and often I find that they're pretty open, and I don't get the sense that I'm being told like an extreme amount of drug to try and get more. Like I'm generally told, oh, I use an 6 times a day, or you can get a good sense of how much is being used. And then often an approach I've seen and that I've kind of loosely applied is you take that like oral morphine equivalent, or you know, take that number and you start at a third or a half of that and then titrate up. So often it'll end up looking like a regular dose every 4 hours. So it can be anywhere from 4 to 10 to 12 milligrams every 4 hours of short-acting hydromorphone with some PRN breakthrough. And now Tommy presented some data at the Atlantic conference that said patients can have up to 1,000 oral morphine equivalents of use per day in the community. And you translate that to hydromorphone, which so you divide that by 5, and then you divide it up. And he's basically, patients can end up on as much as 30 milligrams Q3 hours of hydromorphone. I've not gotten to that level yet, but that is a number that has been spoken about previously and shown in the literature as like an equivalent to what a lot of people are using in the community. And so I only say that number, not that I think that's the number you should jump to, but so that you feel comfortable with the lower numbers, or that 12 milligrams Q4, or that whatever dose you land on based on their community use.
Absolutely.
Yeah, it's a moving target. It can be tough, and I think having lots of breakthrough available is the way to do it. You're not gonna have their pain managed immediately, but knowing that there's breakthrough there and that you're engaging and that you're like, I do want to help your withdrawal, I do want to help your pain. As long as they know they're being helped and that you are approaching it in a way that you're being flexible and trying to treat it, they should remain engaged. I think there is an acknowledgement that they're not going to feel normal immediately.
Yeah. Steve, thank you so much. I think this is great. Obviously this is this is a project that's going to be ongoing, and thank you for keeping us engaged, and conversely we'll do the same and continue to do this better and better and better. So thank you for your time and your talk. Next week, Dr. Mark Peltier from Case Western in Cleveland, formerly of the New Brunswick Heart Center, will be speaking to us on some of his reflections on his time here at the Heart Center, and obviously and beyond. So stay tuned for another exciting installation. Everyone, have a great day.
Thank you.
Thank you.
Steve.